Good morning, everyone. Welcome to our Wednesday presentation. Our presenter today is Dr. Michelle Human. She's a dedicated hematologist at Ampath, where she combines a passion for science with a special interest in coagulation. Her journey began at the University of Pretoria, where she earned a BSc in Human Physiology, followed by a Bachelor of Medicine in Surgery. She went on to serve her internship and community service at Tembisa Hospital, gaining valuable experience in hands-on patient care. In 2021, Michelle completed her postgraduate studies in hematology at Sefako Makgatho Health Science University, where she expanded her expertise, and she recently earned a distinction in the Principles of Patient Blood Management, hosted by the University of the Free State. We're excited to hear about your lecture, Michelle.
Thank you, Cornel. Okay, so today I'm going to talk about Factor 5 Leiden, and it's quite interesting. So I'm just going to give the outline of the presentation. First of all, I'm going to talk about just the introduction, epidemiology, and then not to bore all you guys, but I'm going to just recap the coagulation cascade just to make sure we all understand the pathology of Factor 5 Leiden. I'm also going to talk about the mutation itself and the factor, the risk factors accompanied by patients that's actually got an increased risk of thromboembolism, and then how we diagnose these patients, and I'm also going to touch on the management. And in the presentation, with my references. So what is thrombophilia? So this is the tendency to develop deep vein thromboembolism, and it's based on a hypercoagulable state. This is owing to inherited or acquired disorders of your blood coagulation system or the fibrinolytic system. So it's important to know that this is a multifactorial disorder, and it's usually resulted with interaction between an array of acquired and genetic factors. So as we all know, the Burgos triad, it's a German physician that indicated for us how these blood stasis occurs, and it's got to do with altered blood flow, blood stasis or pooling that can increase, blood touching the vascular endothelial system, as well as injury to the vascular endothelial system. We know about inflammation and infections, and then the hypercoagulable state. The hypercoagulable state could be due to increase in your coagulation factors or decrease in your coagulation inhibitors. That will say the brake on your coagulation system is not functioning properly. And then just to keep this triad in mind, I'm going to talk about a physiological state during my presentation where all three of these factors are actually affected, and these patients are going to increase risk of developing thrombosis. So you guys can already think about what type of physiological state that is. So what is Factor 5 Leiden? So first of all, Factor 5 Leiden is a genetic mutation in one of the clotting factors, namely clotting factor number 5. So what does it do? It renders your Factor 5, both the activated and inactivated forms, insensitive to activated protein C. So the function of activated protein C is to actually break down Factor 5, put the brakes on the coagulation system and protect your endothelial system of not overcoagulating. But with a mutation in the Factor 5, it is rendered inhibited, or it's inactive to be broken down by activated protein C. And this increases your risk of thrombosis. So it's named after the Dutch city of Leiden, where it was first discovered in 1994. There's a nice picture of Leiden. So it is very common in the Northern European ancestry. And you can see it's the areas indicated with the blue. These, the people from these areas are actually at high risk, or actually has got a high incidence of having Factor 5 Leiden mutation. Some of the journals that I read, it's actually every 1 in 20 persons got actually a risk of having Factor 5 Leiden. And as you can see, Netherlands is quite near all these blue areas, and it's in Netherlands where it was first discovered. So epidemiology continues. So Factor 5 Leiden is the most common inherited thrombophilia, with an approximate incidence of 5 to 8% in the heterozygous form and Caucasian people. So the incidence is very low in Asian, America, Australian, and Africa people. As you can see, in Asian people, it's actually so low, 0.4, and in our African population, about 1.2%. Keep in mind that it is low, but it do occur in these population people. They say if you're heterozygous for this genetic mutation, it increases your lifetime risk of thrombosis by 7-fold. While if you got 2 of these mutations, being homozygous, it increases your risk by approximately 30 to 150-fold. So there's different references that you can use, but on average, it will increase your risk about 80% if you do have 2 of these mutations. That will say inherited one from your mom and inherited one from your father, or and having 2 of these mutations. So many individuals that are heterozygous for this mutation will actually never develop a blood clot. They can live until 80 with no complications. So this is actually the interesting part of this disease. It increases your risk of developing DVTs. And just for completeness sake, I put in the thrombophilia causes. And as you can see, like I mentioned, the factor V Leiden is the most common one, followed by your prothrombin gene mutation. That's about 3% occurring in the Caucasian population. And then for interest sake, I put in protein C and S deficiency because I'm also going to talk about it. But as you can see, it is a rare cause of thrombophilia. So just the background, what can actually cause the risk of venous thromboembolism? So first of all, any woman of childbearing age who is not on oral contraceptives, they've got about approximately a risk of 1 in 10,000 per year to develop a DVT. The risk then increases if you take oral contraception to 1 up to 4 in 10,000. And then another interesting thing, those with a first degree relative or history of VTE, the risk doubles from 8 per 10,000 per year. This is even in the absence of identifying thrombophilia. So in the presence of a heterozygous factor V with the use of combined oral contraception, it increases the risk of thrombosis to 35 to 40 per 10,000. So this is what I want to indicate. So even though you're born with a heterozygous mutation, with increase in age and exposure to other risk factors, your increase for developing a blood clot increases. This is not to bore you guys, but I just want to show you quickly a recap of the coagulation cascade to make sense of where this mutation occurs and what happens. So first of all, we know a coagulation cascade is divided into our internal coagulation cascade and external, and then a common pathway. I just want to show you guys that you can see for factor 10 to be activated, factor 8 needs to be a cofactor. For thrombin to be activated, factor 5 needs to be a cofactor. And this is a cascade. So you can see with every step occurring, the clot will become stronger and more more stronger and actually resistant to breakdown until it forms an end of fibrin clot. There's multiple steps that could be regulated in the cascade, and this is what we're going to focus on now. We can see that are extrinsic, but it actually means is that the tissue factor on your endothelial will activate the clotting cascade from that side, and then contact activator like collagen within your system will then also activate it from your intrinsic side, and at the end it will form a stable fibrin clot. So when factor 5, the procoagulant clotting factor, it actually amplifies the thrombin generation. But we've got a protective system or a coagulation inhibitor system in our body, like the brakes on the coagulation system. And that is where protein C plays a role. But protein C actually breaks down factor 5 to prevent too many clots forming on the endothelial system, but it also breaks down our factor 8. And that is our regulatory pathway that we need in our system to prevent clots of forming. This is in a nice balanced way regulated in the blood. So if you've got too many inhibitors with not a lot of factors, you'll have an increased risk of bleeding. But the opposite happens. If your inhibitors are not working properly, you've got an increased risk of thrombosis. So we need your body is a built-in balance, and your body will function in a way to prevent overclotting forms. Except if you've got the mutation factor 5, it will increase your risk of developing thrombosis because your inhibitors can't work. So that means your factor 8 and factor 5 will increase, leading to a state of risk of thrombosis. So the anticoagulant system of the protein C that I want to explain. So on our endothelial system, we have thrombomodulin that is built in on the endothelium. And at the end, when thrombin is formed, it actually also plays a role in the negative feedback as well as positive feedback in the coagulation system. So with the presence of calcium and protein C binding to protein C receptor, we activate protein C. Another important factor is that protein C needs a cofactor, protein S. And when your activated protein C and S bind together, they actually break down factor 5 and 8, putting the brakes on the coagulation system. So just for completeness sake, protein C and protein S is very important to break down factor 8 and factor 5. But you can also get an inherited protein C deficiency that's also autosomal dominant. Type 1 just means that there's a decreased amount of protein C produced, and type 2 is a functional. There's some mutations causing an abnormal function of type protein C deficiency. Also important to remember that you do get acquired protein C deficiencies, and this would be in an acute state where they're actually being used up. It's the same that occurs in DIC. Your brakes of your coagulation system is overactive, your protein C is being used up. Another cause of protein C deficiency is liver disease. Protein C and protein S is a vitamin K dependent clotting system or proteins. So they can also be decreased in vitamin K, especially warfarin. There's also antibodies that can actually inhibit your protein C that can occur in antiphospholipid antibodies. And another interesting thing is in sickle cell disease, your protein C is also decreased. They said that the sickling of the red blood cells actually absorb all these protein Cs, as well as being overused because of sickle cell disease got an increased risk of forming thrombosis. And then with uremia, it's also the same. You can get autoantibodies that break down protein C. Another important thing that I just want to mention about warfarin is warfarin also breaks down your vitamin K dependent factors, and this is the interesting part why we want to actually start the patients with low molecular weight heparin before starting with warfarin, and it's because of this process. Protein C has got a short half-life, 6 to 8 hours. So if you start vitamin K antagonists like warfarin, you will inhibit the inhibitory system of your coagulation cascade. And these patients have an increased risk of thrombosis. That's why you want to start the normal heparin and then transform into warfarin while the INR is normal, to actually prevent skin necrosis that's caused by the increase thrombin formation because you now inhibited your protein C. And another reason why protein S could be deficient, like I mentioned, is also vitamin K antagonists, but also in chronic infections. Important also in HIV people, they've got a decrease in free factor or protein S. And this is also a risk for HIV patients or at increased risk of forming thrombosis, as well as you can see in patients with varicella infection. It's these viruses that actually uses up all your protein S. There's also a decrease in nephrotic syndrome. They're being excreted from your system. And then with immune diseases and cancer, you can get a decrease in protein S. And this will all affect the brakes on your coagulation system. It will increase your risk of forming a thrombosis. So what is factor 5 Leiden mutation? So it's inherited in an autosomal dominant pattern. So what does this mean? This means that you can inherit one copy of the mutated gene from each patient or from a parent. Heterozygous means if one of your parents got the mutation, the children's got 50% chance of getting the mutation, an increased risk of thrombosis forming. And if you've got a homozygous patient, there's actually 100% chance of your children being a carrier. So individuals, like I explained, heterozygous is 1 mutation, homozygous 2. And if you've got homozygous, you've got a very high increased risk of thrombosis, 80 to 100% chance. So what is the mutation? So it results from a single point mutation at your factor V gene, where guanine is replaced by adenine. And this actually changes the amino acid at that area of the protein, where arginine is replaced by glutamine. And the form of the protein then changes, and your activated protein C can't break down factor V because it don't have access to the protein where it's supposed to break down factor V. Therefore, there will be an increase in coagulation because of the enhanced procoagulate factor of activating factor V, as well as the reduced function of anticoagulant role of factor V. But there's actually factors that may increase your risk in thrombosis when you do have factor V Leiden, and it's usually your blood groups. If you're non-O blood groups like type A, B, AB, they are associated with higher levels of factor VIII. Also, if you have activated protein C resistance, that will say when you have a protein S deficiency, I mentioned all the acquired causes, but as well as an increase in factor VIII. Estrogens play an important role because if you're on oral contraceptions, it decreases your protein S levels, but it also increases your coagulation factors, especially factor VIII, 9, 10, and 11. So that's why these people that's on oral contraceptives got an increased risk of forming thrombosis. And then if you've got a heterozygous factor V Leiden, it actually increases your risk more. If you do have a combined antiphospholipid syndrome, it increases your risk more, as well as cancer, renal dysfunction. And another major factor that plays a role is the increase in BMI. And then smoking, it also causes endothelial damage that will put you at risk of developing a blood clot. So who should be tested? So first, if you have an unprovoked venous thromboembolism at any age, but especially in people of less than 50 years. If there's a history of recurrent venous thromboembolism, venous thrombosis at unusual site, like cerebral, mesentery, hepatic, or portal. There's a strong history of family of thrombotic disease. As I mentioned in the beginning, if you've got a mother or a father that's presenting with a DVT, there's an increased risk of you also having it just for being with the genes that you actually inherited. And then venous thromboembolism during pregnancy, as well as the postpartum period. That's due to all the hormonal changes in the body. And then also the use of oral contraceptions when you develop the VTE on them, as well as hormonal replacement therapy when you're in menopause. And like I mentioned, if you have a first-degree relative member with a VT under 50, that's when you want to test if there's an inherited cause. And in the beginning, I spoke about a disease, or not a disease state, a physiological state, where Virchow strides being affected by all three the areas, and this would be in pregnancy. So just by being pregnant, it increases your risk of a VTE by 10 to 20-fold. And this is even higher when you've got an underlying factor V Leiden mutation. So what are the other complications that can occur when you have a factor V Leiden and you're pregnant? So first of all, there's a lot of research being shown to get placental-mediated complications like a rupture placenta. They also can have an increased pregnancy loss, stillbirth as one of the causes. And then hypertensive disorder. These patients can also have a risk in preeclampsia as well as HELLP syndrome. So it's quite interesting that these patients, if you do have a history of PET, it's interesting to actually test these patients who don't have a factor V Leiden mutation. Because with the history of pregnancy losses, we all focus on antiphospholipid syndrome, but also to remember factor V Leiden could also cause this. So why is pregnancy at risk? It's because pregnancy is a hypercoagulable state. And this is actually that they say it's a state of evolutionary protection against hemorrhage in childbirth. And a lot of things happen to prevent actually increased risk of bleeding. So first of all, as you can see your increase in your coagulation factors. Fibrinogen is an acute phase reactant. We know that it increases in pregnancy. Factor 8 decreases tremendously in pregnant patients as well as factor 12, 11, and 10. Unchanged is actually your factor 5. And you get a reduction in your platelets as your pregnancy progresses. And another interesting thing, pregnancy causes a decrease in protein S. So to be more specific, you can see how these factors are being changed. You know, von Willebrand carries factor 8, and it also increases tremendously when the patient is pregnant. And that's why von Willebrand disease type 1 is difficult to diagnose in a pregnant patient. And as you can see, protein S decreases, but there's no change in protein C. So what is the signs and symptoms of that can occur? So first of all, the major clinical presentation is with a thromboembolism. This could be by deep vein thrombosis and pulmonary embolism, and then thrombosis in abnormal places like cerebral, mesenteric, and portal veins. And there's also a risk of developing superficial venous thrombosis. And this is just a picture of a superior sagittal sinus thrombosis that a patient developed. So how do we diagnose factor 5 Leiden? So first of all, it's a proper history. It's nice just to get spend a little bit of time and get history of thrombosis and family history. First, your mother and father, sibling, grandparents. You'll usually see a trend in the family that will give you an idea of to investigate. To properly investigate, also do an FBC and a peripheral smear, just to make sure that you're not missing in the underlying cause, that inflammation, cancer, that can also increase the risk of thrombosis. And then to start with a coagulation profile, just a proper PT, fibrinogen, PTT, and I'm sorry, you see my D-dimer has been cut off, but just a full coagulation profile. Then, if the doctor wants to investigate for thrombophilia, at Ampath we have a thrombophilia screen where we will actually do the antithrombin levels, protein C, protein S, and we'll do our factor 5, Leiden, and prothrombin gene mutation. So this is via PCR. We'll also do an antiphospholipid lipid screen, which will combine immunology and coagulation assays. And then, if needed, we'll do homocysteine level. And just for completeness sake, I put in this table that I thought is quite nice, where you can combine your inherited causes of thrombus as well as your acquired factors that I did mention in the presentation. So what do we do at Ampath? So first of all, we can start with doing an activated protein C resistance. I think all the other labs do it as well. It's just a screening test. And then for confirmation, we'll do the PCR, the genetic test for factor 5 Leiden mutation. It's activated protein C. So the original test for activated protein C, it's just involving measurement of the APTT in the plasma sample with or without the addition of extragenous activated protein C. So in a plasma without activated protein C, the addition of activating protein C will actually inactivate factor 5 and 8, and it will prolong your clotting time. And this is in contrast with a sample with factor 5 Leiden mutation, where the prolongation of the time will be less if you add activated protein C. So we then do a ratio, and if your ratio is then less than 2, it's an indication that you have got a factor 5 Leiden mutation. This is just a screening confirmation. We will need to do the genetic test. That's going to be a PCR test. So how do we manage these patients? So first of all, if you now do diagnose a patient with factor 5 Leiden and it's heterozygous and there's no symptoms, you do not have to treat this patient. You can, if the patient presents with a DVT or pulmonary embolism, start on anticoagulants. And then also important, a lifestyle modification. Patients who are heterozygous, it's important to educate and counsel them to avoid smoking. It would be the best, not to give combined oral contraception, and also to avoid long stays, immobility, actually also long flights. It's best for them to try and get up and move a little bit, as well as very important is to stay hydrated. Dehydration causes an increased risk of thrombosis. So patients who do with factor V Leiden who do develop a DVT should receive the standard anticoagulation therapy. It's just the best to start with a low molecular weight heparin and then overlapping to warfarin if you decide to use warfarin for about 5 days until your iron are stable. Then the duration of your anticoagulation therapy depends on whether the thrombosis was actually provoked. Then it will be 3 to 6 months. If it's unprovoked, you're going to consider extended therapy. The direct oral anticoagulants you can also use, and I've put in a table of the dosages for treatment as well as prophylaxis if you do not want to use warfarin. Very important in a pregnant lady with a factor V Leiden, it's best to start these patients on Clexane, low molecular weight heparin throughout pregnancy as well as 6 weeks postpartum. For completeness sake, I just put in the up-to-date table. This is just also to just show you guys to actually just the different methods of contraception, like intrauterine devices are best in these patients, just to avoid the combined estrogen and progesterone. And then also just education for the patients. And if you read, I did mention the treatment of the thrombosis. So at the end of my presentation, so the special consideration is just pregnancy and factor V Leiden. I think it's important if there is a family history to test these patients and then to start low molecular weight heparin in view of all the other placental complications that can occur with factor V Leiden. Like I mentioned, you need to keep low molecular weight and then also low molecular weight heparin in pregnancy, and also screening for the family is important, especially if you detect a mother that's homogeneous and now she's got a daughter, and this will just be to prevent your risk in giving combined giving oral contraceptive in these patients. So in summary, factor V Leiden is a common gene mutation and it increases your risk of blood clots. But to remember that only 5 to 10% of factor V Leiden that's heterozygous will experience a VTE during their lifetime. This is the reason why it's a highly variable phenotype, and this is actually incompletely understood. So screening for factor V Leiden in general population is not recommended. The reason is if you do have it, it will cause more anxiety, and some people not present with any clots throughout their life. So, and it's also too important to understand that inherited hemophilia is really the sole cause of VTE. You have to look at it in a whole, as well as your acquired risk factors, as well as your genetic pre-mutations. And that's my presentation.
Thank you, Michelle. Thanks for the insightful kind of presentations, and it's really quite highlights quite factor V Leiden, but something to come out clearly here. Just a simple question. Should we be testing factor V Leiden on the Black patients?
Yes.
Since the gene is only really up there, or do you think there's some... with South Africa is different. Let's look about the rest of Africa where there was no Dutch before.
Yeah, so in our population, I mean, if you do have a lady that's not presenting with DVT, it's best to do your entire thrombophilia screen, because sometimes the family history is not, set in stone, and we've diagnosed factor V Leiden in African populations. So just to say that it's rare, it's not to say that you won't see them. So it's best if you do have that criteria where they get a blood clot in less than 50, there's a family history, it's best to do your thrombophilia screen. But if the lady is now presenting with you, you don't just screen any population. You'll have a risk or indication you just screen.
Yeah, so I think basically clearly that I think for Africa, we don't have our own data to really reflect the incidence of the factor V Leiden in the continent, but something that perhaps maybe we need to start considering retrospective studies to actually look at that. And I mean, of course, we know that, of course, most of the African countries, they don't have the ability to test for factor V Leiden. And it's really South Africa is the only country probably that we have that capabilities to do that. And maybe in future, we should actually get our own data on that. Yeah, factor V Leiden. And then the second questions related to heterogeneous factor V Leiden deficiency. And most of these patients, of course, they present late in their life. Should we be looking at other precipitant factors? Because why should those patients not present their 40s, 50s with factor heterogeneous, not in early as compared to homogeneous? Should we attribute that 100% to them, or we should look for secondary causes of precipitant?
I think you also should look for secondary causes because it increases your risk. So, if you get older, you'll get cholesterol, you'll get other inflammatories, you get autoimmune diseases, and that just actually flares up or increases your risk of thrombosis. If you're a healthy person, say, well, not all, but not smoking, don't have cholesterol, you can have a heterozygous and be 90 and never ever develop a clot. So I think if you do have a patient, you have to exclude your secondary causes as well. And if you do see there's a few of them, then investigate, and then obviously it will be best to put this patient then on an anticoagulant because the risk is too high.
Thank you. I think the take-home message is clearly anybody with heterozygous, please look for secondary cause because might be a precipitant on that. And then the last question. Should we put in this patient for long-term anticoagulations with a heterozygous and homogeneous, or do you think that we should be able to differentiate the two of them?
For homogeneous, you'll have to put on lifelong. They've got an increased risk, especially in pregnancy. You need to monitor these patients. Complications are high. With heterozygous, you'll treat them as a DVT that occurred without having the genetic mutation. But that in mind, you have to take each patient as it is, because that patient can have a high BMI, smoking, and now heterogeneous. So you have to look at that patient. Then you have to make the decision, what's the risk of this patient? Because you can see all the factors adding up. So if I have a patient who's not going to stop smoking, that I'll rather put them on a longer time of anticoagulation. Start to DOAC, because those patients are also difficult to monitor.
Thank you.
And just to add on to that last question, I was thinking, you've diagnosed a heterozygous factor V. You've got a provoked DVT.
Yeah.
Would you stop anticoagulation actually?
No, he'll continue.
I think that would probably be the safer way of managing this patient.
No, I think, look, the question that I think always you look at the burden of the clots. The question that I think I always say is, if the fact that this patient now with heterozygous developed DVT means something has gone wrong in his hemocoagulation system, looking at the triangle. And I think it would be very, you have to really have open discussion with the patient, especially if lead to pulmonary embolism. Means chance of recurrence are very high. So it means they're just like a ticking bomb. So perhaps it's worthwhile actually to give them lifelong anticoagulation. Okay. But if they're younger and you find that maybe what happened during pregnancy, then then you might discuss. But I think for me, most of the time I will go to the thing. But then for the last question, patients will come to say, listen, doctor, my blood clots is gone. I don't want to have this blood thinners. Can I take Ecotrine? What's your response?
I don't 100% agree with the previous. But so if you've got a heterozygous patient with factor V Leiden, and there's a precipitating factor, it's usually patients on estrogen. They've been on a long flight, they've taken estrogen, they didn't know about their genetic disorder, and they develop a DVT. You would treat them, or I would treat them, and then you would take away the estrogen, the precipitate, and then monitor them. I don't think they will need lifelong, because
I think my concern is that at which point, because this is a patient, at the end of the day, there's a patient in front of you. If another clot happens and you had stopped that anticoagulation, knowing full well they had a heterozygous factor V Leiden, which predisposes them, we can't predict, are they going to go on another flight? Are they going to do this X, Y,
If you explain to them, and you, for instance, that this is what is happening, because it influences their life as well, being lifelong on
it does. But
if you use Lexan beforehand, before you go on a long flight, if you've got a job that requires a lot of sitting, you have to walk around, you stay away from the estrogen contraceptives.
And then a clot happens.
And if it doesn't,
But even
I think I'm not this discussion so much. So now the question that yes, I think look, both speakers really have a very good valid reason. Actually, that's the reality. But I think based on my clinical experience with level-wide evidence, there are quite very few things that you must look for if you really should continue coagulation or not. Okay, it's not based on opinion. We have to look at that. There are quite a few studies done. And one of them is where we look at what we call HADU2. Okay, means somehow we look at the risk score for these patients. If they're obese, if they're having an arrhythmia in their legs, if they're female on contraceptions, if they have high D-diamonds, and that means those patients you carry on forever. So it's not really about the heterozygous or whatever is there. It's really looking about the scores that are available. And I think maybe our next presentation, we might build those scores that are available. And second thing, if someone got DVT, I think before you discontinue anticoagulation, send the patients back for radiology. And if they have the clots that is just recanalized, the risks are very high. If they're obese, BMI more than 25, the risks are very high. And obviously, if they're having if they're gonna fall pregnant, the risks are high. If they have underlying myeloma, the risks are high. So I think maybe the right thing is to individualize each and every patient. So both speakers, there's no right or wrong, but it's about the context actually where you want to continue or discontinue your anticoagulation. Intermeetings or whatsoever is there. So maybe we should look at that and look at what are the studies that are done. I know there are quite a lot of few scores that we have. And I remember Prof. Richard was when I was at Joburg General Hospital. He will always bombard us based on that. And I think there's a way that we can look at them. And I think one of them is HADU2. I think I would just Google it a bit. It's called MEN-DU2 and HADU2. And that's the score that we decide how to continue thrombophilia on those patients. 1 second. Yeah, Connor, you can carry on.
I've got a question. So, well, we test a lot for it. We get a lot of patients with DVTs, with PEs, and we test for factor 5, protein C, protein S, the antithrombin 3. You know, I haven't seen an antithrombin 3. Yeah, protein C deficiency we see once in a while, but also very rare. And it's usually the heterozygous. We see actually more the antiphospholipids.
Yes. That's a quiet cause.
Yes. So can you have both?
Yes. Yes. So and you can, if you can have factor 5 Leiden with prothrombin 2 mutation, then you can't find heterozygous. And for that, you need lifelong anticoagulant therapy or increased risk. So if you do have antiphospholipid factor 5, you are at a very high risk. So continue with anticoagulant.
Yeah. All right. So here the score is called HERDOO2 rule for discontinuing anticoagulation in unprovoked venous embolism. This ordinarily not applied for provoke, but obviously can be used. So used in women more than 18 years old with unprovoked VT and do not use in patients with any of the following at the time of VT. Okay, so you look at quite a few things. You look at the D-dimer levels, if less than 2.50, and ours I think 2.5, and then BMI, you look at the age and all that. Then you have a score, 0.0, and then 3%, and all those. So this is really a score that's available, and I know that there's actually more out there. So maybe next time we talk about what scores can you use. All right. Okay. Any other questions? I think it's getting hot here. Horrible. Otherwise, thank you. Let's get the rep.
Was that section?
The rep.
I see there's a second page.
Dr. Kohli?
Yeah, good morning. No questions from my side.
Thank you. Any comment? You can't be sitting there in hyper alone. You have to say something.
No, great presentation. I think we rarely see that. I think it was only on one occasion that I picked up that factor 5, but that was already diagnosed before presentation. Otherwise, the routine screenings, I haven't picked up any.
Was that patient coagulation stop? Was that the reason of recurrency?
No, the patient anticoagulation was continued. We opted to continue for life. Yeah, I think it defaulted and now had another clot before presenting. But on careful history, we picked up that that was diagnosed much earlier, and there was a strong family history as well.
Was it heterozygous or homogeneous? Can you remember the mutation?
I can't remember. Yeah.
Yeah, but it would be very nice. I think maybe, and you know what, as I say, with South Africa, we have so many data. Imagine if you could collect all the thrombophilia from the lab and actually just look at heterozygous and do a study, just looking at all these patients, follow them, how many of them during that taken anticoagulation, how many have stopped, how many actually have recurrence. Then you have a really nice data. But thank you, Dr. Okoye. Thank you, Olis, for attending the presentation. We appreciate your presence. I'll give you some key points. If there's no question, in absence of Leanne, who is the chair, I will take over and say thank you, everybody, and we appreciate it. Remember, we have presentation tomorrow in every week.